We'll continue the section on collagen vascular disease with a discussion of the various types of vasculitis. We'll continue the section on collagen vascular disease with a discussion of the various types of vasculitis. We can think of vasculitis from a diagnostic standpoint as having large vessel involvement or medium vessel involvement, and whether or not there is immune complex deposition or not. The large vessel involvement in terms of vasculitides are in giant cell arteritis or temporal arteritis, Takayasu's arteritis or pulseless disease, or Collagen syndrome. Medium vessel involvement can be seen in polyarteritis nodosa or in Kawasaki disease in childhood. We can think about small vessel involvement with immune complex deposition with hypersensitivity vasculitis, Henoch-Schönlein purpura, Behçet syndrome, cryoglobulinemia, and the vasculitis of the rheumatic diseases such as SLE and rheumatoid arthritis. Small vessel involvement without immune complex deposition, or pauci-immune vasculitis, can be seen in Wegener's granulomatosis, Churg-Strauss vasculitis, or microscopic polyangiitis. Whereas in the immune small vessel vasculitides, there are immune complex depositions, the pauci-immune small vessel vasculitides have often granulomatous inflammation or frank necrosis of the small vasculature. So here's a picture of some of the involved entities in the large and small vessel vasculitis. Looking at the top, we've covered the small vessel vasculitides, microscopic polyangiitis, and Wegener's granulomatosis. We'll cover those in a brief moment. The medium-sized vessel vasculitides, polyarteritis nodosa and Kawasaki's disease, and the large vessel arteritis, giant cell or temporal arteritis, and Takayasu's arteritis. And you can see which specific parts of the arteriovascular tree are going to be involved. Vasculitis is a multi-system inflammatory disease with rapidly progressing major organ dysfunction as the macro and microvasculature is involved and destroyed. The complaints in the setting of vasculitis are often vague and nonspecific, including fever, weight loss, malaise. The laboratory evaluation often reveals a high erythrocyte sedimentation rate and also a high C-reactive protein, as well as severe anemia or thrombocytosis. There can be evidence of small vessel inflammation with, in terms of the kidneys, you can have an active urinary sediment with red cell casts. In the lungs, you can have hemoptysis and progressive dyspnea in the setting of vasculitis. And in the skin, there can be hemorrhage out of the skin or palpable purpura, non-blanching lesions under the skin. The acute neurologic changes associated with the vasculitides include foot drop or alterations in the mental status. Diagnosis of the various types of vasculitides require tissue biopsy to determine the size of the vessel involved as well as the histologic features of the vessel inflammation, whether or not there is immune complex deposition or vessel wall necrosis or with granuloma or giant cell involvement. Angiography of the mesenteric or cerebral vasculature is also performed as is clinically indicated. In the setting of a diagnosed medium to small vessel vasculitis, in the presentation of abdominal pain, it would not be unreasonable to perform angiography of the mesenteric vasculature, or in the setting of mental status changes to perform angiography of the brain is also clinically indicated. So the diagnosis of vasculitis also relies on tests suggesting immune complex deposition or formation in these tissues. Rheumatoid factor and cryoglobulins are some tests that are used, as well as nonspecific tests such as the antinuclear antibody. Low C3 or C4 levels can be suggested in the setting of immune complex deposition and complement activation in the small vasculature. Tests that suggest necrotizing vasculitis include the anti-neutrophil cytoplasmic antibody, or ANCA. Systemic inflammation is seen with ESRs and CRPs that can be remarkably elevated. So the anti-neutrophil cytoplasmic antibody, or ANCA, looks at immunofluorescence of various types of antibodies within the various neutrophil cytoplasms. So C-ANCA can be seen in Wegener's disease, and this is in 60 to 90% of cases with Wegener's. The P. ANCA can be seen in microscopic polyangiitis or in ulcerative colitis or Crohn's disease. We can detect ANCA by enzyme-linked immunosorbent assays, and when we see ANCA positive, we can see antiproteinase 3, which is common in Wegener's disease, or anti-myeloperoxidase antibodies, which can be seen in microscopic polyangiitis. C-ANCA and some of the other immune complex diseases can be seen in malignancies or other types of infections, and granulomatous diseases such as infection with Mycobacterium tuberculosis. C-ANCA is going to be positive in 95% of patients with Wegener's vasculitis. And Wegener's vasculitis is characterized by necrotizing granulomas within the small arteries and veins. Classically, the triad of sinusitis, lung involvement including hemoptysis and dyspnea, as well as glomerulonephritis can be seen. Unusual manifestations of Wegener's vasculitis include peripheral arthritis, episcleritis, pericarditis, and mesenteric vasculitis. So this disease is associated with a particularly poor prognosis, but when treated with Cytoxan, can improve the prognosis somewhat. A high level of suspicion needs to be raised in the setting of any kind of systemic disease for a disorder such as Wegener's. Any type of pulmonary renal syndrome where you have hematuria and hemoptysis, you need to consider Wegener's very strongly. Microscopic polyarteritis is very similar to Wegener's granulomatosis and can sometimes be indistinguishable. It is associated with P. ANCA and an anti-myeloperoxidase. The treatment is very much the same as Wegener's granulomatosis. The distinguishing clinical feature between microscopic polyarteritis and Wegener's disease is that it is much less likely to have lung involvement. Henoch-Schönlein purpura is most commonly seen in children, but can be seen in adults up to middle age. It is a small vessel vasculitis affecting the gut, the kidney, and the skin, and there is the stereotypic lesion of Henoch-Schönlein purpura that's seen in the picture on the right. It is associated with infections of the upper respiratory tract. Severe renal damage is rare, and most of the time supportive therapy, including fluids and perhaps ACE inhibition, will be indicated in Henoch-Schönlein purpura and renal disease. And in really any disease, Henoch-Schönlein purpura is most often treated with supportive care. The biopsy shows IgA deposition in these skin lesions and in any other visceral manifestation of Henoch-Schönlein purpura. Churg-Strauss vasculitis is associated with asthma, nasal polyposis, and sometimes the use of leukotriene antagonists. It is a small to medium-sized vasculitis. Diffuse findings, not unlike polyarteritis nodosa, are common. You can have Churg-Strauss vasculitis in the lung, gut, skin, and kidney. And what you see on tissue biopsy in Churg-Strauss vasculitis is a predominant eosinophilic infiltrate with granulomatous formation. Steroids are very effective in treating Churg-Strauss vasculitis. Polyarteritis nodosa is a medium-sized vessel vasculitis, and it is associated with the hepatitis, specifically hepatitis B. Mononeuritis multiplex and abdominal pain can be seen in polyarteritis nodosa, as well as arthralgia and a stereotypic rash. PAN can be diagnosed by biopsy, and treatment includes treating the underlying hepatitis B infection. Steroids and other cytotoxic medications may be necessary if the visceral involvement is severe. Takayasu's disease, or the so-called pulseless disease, affects Asian females more than any other demographic. It is so called because there can be complete occlusion of the medium to large vessels, and these symptoms of claudication, including extremity pain with use and exercise, can bring the patient to clinical presentation, but the ongoing stenosis after the inflammation is resolved can be common. The treatment of Takayasu's arteritis is with bypass of the inflammatory lesion in the artery, and there are usually multiple bypass procedures which can be performed. Behçet's disease is a systemic disease which has eye involvement and mucosal involvement, specifically of the oral mucosa. There can also be CNS involvement. It is a relapsing and remitting small vessel vasculitis presenting as recurrent orogenital ulceration. Pathology is common, and what pathology is a pustular lesion after a solitary skin prick, which is seen 24 to 48 hours after the initial skin prick is performed. It can lead to a hypercoagulable state resulting in thrombosis of the large vessels. The treatment of Behçet's disease is ongoing and can include anti-tumor necrosis factor therapy. The diagnostic criteria for Behçet's disease is recurrent oral aphthous ulceration. And aphthous ulceration is really nothing more than an idiopathic canker sore. There can be 3 episodes seen within 12 months. Once you see the recurrent oral ulceration, you need to be concerned if you see recurrent genital ulceration, any type of anterior or posterior uveitis seen on slit lamp exam, or retinal vasculitis seen by an ophthalmologist. The erythema nodosum-like lesions seen in the skin, or the papulopustular skin lesions, can be seen in these patients as well. And the pathology test, which we talked about, where a skin prick generates a pustular lesion 24 to 48 hours after the initial skin prick is performed. There are a variety of diseases that can present as vasculitis syndromes or can mimic any of the specific vasculitides. Infectious endocarditis can mimic a systemic vasculitis with recurrent fever, low-grade malaise, and generally not feeling well, as well as peripheral ulcerations, the Osler's nodes and the Janeway lesions, as well as the splinter hemorrhages in the nails, can make it seem as if there is a vasculitic process going on, but your suspicion must be raised for bacterial endocarditis in these patients. HIV infection can also mimic a systemic vasculitis, and viral hepatitis, hepatitis B and C specifically, can mimic the vasculitis. Paraneoplastic syndromes, again with long-standing chronic malaise and different types of skin rashes, can mimic a vasculitis. Atrial myxoma can have peripheral embolization of a space-occupying lesion within the atrium, and that can look much like a systemic vasculitis. Cholesterol emboli syndrome can cause a peripheral eosinophilia and vasculopathy as well. Various types of drugs that can mimic vasculitis syndromes are drugs that will cause vasospasm, including ergot alkaloids, cocaine, and amphetamines, even methamphetamine. Useful tests to differentiate these vasculitis mimics from any other would include blood cultures for the diagnosis of bacterial endocarditis, as well as transthoracic and transesophageal echocardiography. Looking at viral hepatitis antigens and antibodies, HIV test, a urine tox screen, or all the way to angiography to see how the vasculature is involved, can help differentiate the non-vasculitis cases from a case of true vasculitis. You need to consider that the questions you're being asked are vasculitis mimics when there is a presence of a heart murmur, when you have splinter hemorrhages in the nail folds, or necrosis of lower extremity digits. If you have prominent liver dysfunction, you need to be concerned for hepatitis B or C infection. Any history of recreational drug use, such as cocaine or methamphetamine. History of high-risk sexual activity can raise the red flag for human immunodeficiency virus infection. Prior diagnosis of a malignant disease. And unusually high fevers, such as 103 to 104, can make you be more concerned and raise your suspicion for vasculitis mimics rather than a vasculitis syndrome. Hepatitis B-associated vasculitides can be seen in 10% to 50% of patients with a diagnosis of polyarteritis nodosa. This can present as a systemic vasculitis with abnormal liver enzymes, and when you do the hepatitis B serologies, you can see that there is ongoing hepatitis B infection. The tissue damage is due to immune complex deposition, and the therapy includes antiviral agents for treatment of hepatitis B, as well as steroids, and can even progress to pheresis to try to get the autoimmune antibodies that are associated with hepatitis B virus infection out of the system. Rituximab or Rituxan is becoming an important therapy in the setting of hepatitis B-associated vasculitides. The HIV-associated vasculitides can masquerade as many different types of rheumatic syndromes. Hypersensitivity vasculitis, lupus, PAN, Churg-Strauss, or primary CNS vasculitis can all be presentations of primary HIV-associated vasculitis. The primary therapy in these cases is antiretroviral therapy. You get the HIV under control and the symptoms of the vasculitis may improve. A careful use of immunosuppressive agents may be considered. However, in the patient with human immunodeficiency virus, you may not want to pursue very aggressive immunosuppressive therapy. Other viral infections mimicking rheumatic and vasculitic syndromes. Hepatitis C can cause a mixed cryoglobulinemia. HIV can cause seronegative rheumatologic syndromes. Parvovirus B19 can mimic rheumatoid arthritis. And we've already discussed hepatitis B's association with polyarteritis nodosa. So points to remember for your Step 1 exam. If you have a patient with a complex multi-system disorder, you need to think about vasculitis or a systemic inflammatory process. If a vasculitic disorder is considered, search for its cause and search for the vasculitis mimics as well. Employ tests and biopsies when indicated, but remember to treat the patient and not the test because sometimes the tests can be falsely negative. Rapid diagnosis and treatment in patients with multi-system vasculitic disease is often life-saving. Consider other rheumatologic vasculitis syndromes when the autoantibody results are atypical. And remember that these are complicated syndromes to consider, and the diagnosis is often difficult, and to pursue them as rapidly as possible and to get a definitive diagnosis on your Step 1 board exam as best as you can will help you lead you to the right answer when looking for rheumatologic and collagen vascular disease. That concludes our discussion of collagen vascular disorders and autoimmune diseases. I thank you.